Yes, sir.
Okay, sir. I'm going to present about preoperative evaluation clinic, sir.
Okay.
The preoperative evaluation clinic was developed with the goal of focusing all preoperative clinical services into hospital location to establish a center of visibility, competitiveness, and efficiency. A preoperative evaluation clinic is a dedicated facility where the patients are assessed before undergoing surgery. Operative goals, they provide a centralized site for a preoperative evaluation, avoid logistic shuffling of the patients to multiple hospital sites, provide anesthesia consultation for evaluation of medically complex patients, and establish rapport with patients and reduce anxiety of the patients, improve patient care by providing personalized care, comfort, and convenience, improve education of the patients and families about their surgical procedure and proposed anesthesia care, and including post-op pain control options. Educate patients about what to expect regarding the post-op care, feeding, and discharge needs. Ensure cost-effective ordering of the preoperative laboratory and diagnostic studies. Reduce the number of cancellation and delays in the operative procedures on the day of surgery. Ensure availability of medical records at the time of pre-op evaluation, and provide education and informed consent. Ensure patients and surgeon satisfaction. Components of pre-anesthetic evaluation clinic it is a visible collaboration between the departments of surgery, anesthesia, nursing, and hospital administration. The components are history taking, where past medical history and surgical history of patients are evaluated, and history of medications and history of allergies noted, and history of any previous surgeries or any previous anesthesia and the complication related to them are asked and noted. Physical examination, general and system-wise examination based on the planned procedure, and airway examination of the patients are done. Investigations, routine investigations like CBC, renal function test, and ECG chest X-ray are done. In special cases, echo, PFTs, and based on the patient comorbidities, investigations are done. Risk assessment, use of risk stratification using ESA classification and cardiopulmonary risk stratification are done. Optimization of the health, control of the chronic diseases like diabetes, hypertension, cessation of smoking, and nutritional improvement are planned in the optimization of the health. And patient instructions, patients are instructed about the fasting guidelines and the adjustment of the medications like discontinuation of the antihypertensives like ACE inhibitors, and discontinuation of anticoagulants based on the surgery and the risk of the patient and the procedure. Explanation of the anesthesia of the patient, and obtaining consent from the patient. Location of the pre-anesthetic clinic, it should be easily available from the main entrance of the hospital, and preferably in the OPD block near the surgical specialties. There should be an easy access to the hospital, diagnostic, and other support facilities. The requisite facilities are registration and reception area, adequate number of examination room, patient and family education rooms, room for lab investigation and ECG room, an area for admitting financial and insurance services, and computer support rooms and restrooms. Benefits of the pre-anesthetic evaluation clinics are reduction in excessive pre-op testing, increased patient surgical safety of the patients, reduced post-operative complications, lower the rate of surgery cancellations, better resource and time management, enhanced patient satisfaction. Pre-anesthesia evaluation has been done in DECA surgery. Patients undergo pre-anesthetic evaluation screening 1 to 30 days before and are admitted on the day of scheduled surgery. Outpatients posted for DECA surgeries are routinely screened pre-operatively using questionnaires, telephone interviews, and evaluation at the pre-anesthesia evaluation assessment clinic. That's it, sir.
Okay. So, as seniors who are waiting to take your theory exams, you have now had a good experience of pre-anesthetic evaluation of patients. Okay.
Yes, sir.
In your hospital MIOT, do you have a pre-anesthetic evaluation clinic?
No, sir.
No. So how do you evaluate your patients?
We will go to wards.
You go to the patient's bedside
OPDs.
and do the evaluation. Okay.
Yes.
So why then there's a topic and why they are asking a question of pre-anesthetic evaluation clinic?
Um, we have to optimize the patient before getting admitted, sir. And by
The
seeing
volume
the patient.
is the volume of patients. Supposing, for example, in Stanley Hospital, when I was a PG and I was an assistant, and in my entire service I spent in the hospital, we used to have at least 150 to 200 patients to be evaluated by 7 surgical units, 5 specialty units, and other endoscopic suits and other things. Okay. So it is impossible for even 5 PGs or 10 PGs to go to each and every ward, and all the blocks are situated in various locations. So it is not possible to go to the bedside of the patient and then do the evaluation. Okay. So in such situations, it is better to organize a pre-anesthetic evaluation clinic about which everybody will know, and you can bring all the patients to one location and then have a required number of helping hands, like one senior anesthetist and then trainees. At that point also you have to say in your this thing, how the staffing pattern, you have to say who should be the main person to assess the patient, and whether, for example, you have a first year PG, can you allow him to assess a case of Whipple's disease or liver transplantation patient?
No, sir.
Like Ranjini or Anish Kumar, who have joined 3 months ago, will they be able to assess Whipple's patient or a patient for a renal transplant or liver transplant? They may not be able to do. But it is a place where they can learn how to assess the patient. What are all the things you have to look for? What investigations are required? And what is the important thing you have to take into consideration in each and individual type of patients and surgery requirement. Okay, so that is another important point that has to be added to your answer.
Yes, sir.
But you have said all about the positive sides of this particular clinic. Are there any negative points in organizing a pre-anesthetic evaluation clinic, or rather practical difficulties? For example, in your hospital is a major orthopedic hospital. So a fracture hip patient, it is easy for the patient if you go to the bedside of the patient and evaluate the patient. Instead of transporting the patient from a room to a pre-anesthetic evaluation clinic situated elsewhere, a trauma or a fracture patient, it is very difficult to shift them to the pre-anesthetic clinic just for the sake of evaluation. That is the number one drawback with the pre-anesthetic evaluation clinic. Patients who are not ambulant or who will be in pain when transported, they cannot be. That's why we also should have an option that patients who cannot be transported or who are immobile should be assessed at the bedside. That also you have to add in your answer. Yes. The second drawback I would say in a pre-anesthetic evaluation clinic is, today you have gone and assessed a 84-year-old lady with a fractured neck of femur on the right side. She has COPD, she has diabetes mellitus, she has hypertension, she had a stent about 3 years ago. All the things you have recorded and assessed the thing. And next day you are on post duty off, or you have taken leave and you are not going to be in the OT to anesthetize the patient. Okay, so somebody else maybe have to do that. That person has not seen this lady at all, so he may have some reservations about that. So that is a drawback of having a centralized pre-anesthetic evaluation clinic. So how would you solve that problem? For example, you go and see this patient, how what I described, and Soundarya has to anesthetize that patient next day in the OT. She has not seen the face of the patient at all. So how to overcome this drawback of pre-anesthetic evaluation clinic?
Documenting and quick assessment just before taking
communication. Okay, supposing you find that this patient is a high risk patient with already a stent in position, hypertensive, diabetic, COPD. Okay, so you always call the theatre anesthetist who is going to anesthetize the patient and personally communicate. I have seen a patient so and so today. He is posted for total hip replacement or fixation of the fracture. She has got all these comorbidities, but she is stable. She is on all these drugs. Airway is okay. Back spine I have examined. That's also okay. So you just make a personal communication to the theatre anesthetist and then transfer the information that you have obtained. Okay? So this
Yes.
will be the pattern, and the same thing will happen in the pre-anesthetic evaluation clinic itself. When you have people will be posted there for 1 month, and the next month some other team will come to us do the assessment for that entire month. So the person who is assessing the patient may not be the anesthetist who is going to anesthetize the patient. Okay? So that problem also is a minor drawback in that. But as you say, if you have documented the whole thing, it is the duty of the person who is going to anesthetize that patient in the OT to go through the entire record and make a quick assessment and the examination of the patient before wheeling the patient into the OT and making sure that there will be not any problem. Okay, so that
Yes.
is the only drawback with that centralized or a organization of a pre-anesthetic evaluation clinic. Very good.
Yes, sir.
So I'll just share my screen.